Welcome to this teaching session of the FRCS group, preparing for the FRCS examination. Tonight we have really, thank you for everyone who attended. Tonight we have a guest, really star guest, who's teaching us. He's a mentor of all of us, Mr. Mahaluximavala. He is runs a lot of activities. Really, he's very busy, but he's very well-known trainer and educator in the UK. He's a consultant from Harlow, Princess Alexandra Hospital. He's very busy, has very busy practice, but he's also very interested in teaching and training. He runs the Royal College of England FRCS course, a very well-known and recommended course. We all attended, a lot of, most of the mentors here have attended this course. I attended myself, very good, recommended. You can always, guys, find it here on this website, Doctors Academy. And he's also takes part in a lot of education activity related to the FRCS, including the well-known Cambridge FRCS course run by Orthopaedic Research UK. He's been here with us supporting our group since we started, and we are very pleased to have him with us tonight. So I will over to you, Mr. Mahaluximavala, to start.
Thank you, Firas, very much. So kind of you for this introduction, Firas. And so this topic is prosthetics, but actually it is amputation and prosthetics. Sorry, I just sorry, my screen, I can't get it forward. Just a minute.
Yeah, that's fine. That's fine. So while Mr. Mahaluximavala is working on this, we will. This is very useful presentation, and it's presented in courses in the UK, and it's very useful. And the best way to run it is sort of simulated or type of Viva question and answer, and then we will give you the answer afterwards. So we will encourage you to take active part. So please, anyone interested in being taking part of the hot seat, please raise your hand or send the message in the chat box so I can allocate you, a next opportunity.
Oh, great. So I've got it now. So basic topics like this are important is because these topics like amputation, prosthetics, genetics, orthotics, as you agree, we don't discuss in the coffee room. We don't discuss day to day. Unfortunately, as you know, and all the senior mentors would have told you that these topics unfortunately are part of our syllabus. So I'll try to keep it simple. Those of you who are giving the exam in 10 days, if you can get the knowledge from this to keep it simple, that's great. Those who are giving it later on, once again, it's a difficult topic to get from books, so I'll try to simplify it. So basically, the plan of the talk will be, let's talk about indications and nomenclature, correct words for things which we don't normally use. Then we'll go to surgeon factors. So it'll be the ideal stump, ideal length, etc. Then will be prosthetic factors, and then problems and complication, and less common amputation. So let's start. Firas, can you just ask someone?
Yeah. So Ibrahim, are you still with us? Ibrahim?
Yeah.
So Ibrahim, you are through with Mr. Mahaluximavala for a question, please.
Yeah.
Okay.
So this is your basic science Viva, and I'll start with a few questions. So let's start with the first one. What do you understand by a prosthetic? or a prosthesis?
A prosthesis is an external device helping in replacing body parts or replacing body function.
Okay, that's fine. And if you're shown in the Viva, and once again, it's your basic science Viva, you will be shown a picture of a really open fracture with a vascular injury. And the question then comes to you is, what will you do for this patient? Will you like to do a limb salvage, or would you like to do an amputation, and how will you make your decision? So what will you say for that?
Yeah, actually, this is a matter of debate in the literatures, but the most commonly used helping decision is use of mangled extremity limb score. It will help the surgeon to take the decisions.
So tell me about it.
It is for components. The first part is shock and or age of the patients. Below than 30, from 30 to 50, more older than 50, and the shock, blood pressure above 90, transient responder or permanent unresponder. Then the state of ischemia of the limb. If there is a pulse, or the second stage is pulseless, but the limb is still warm and there is a prolonged capillary refill. And the last stage, that's scored 3, is pulseless insensate cold limb. Then the last component. Okay.
Thank you. And the next question is, the simplest definition would be, a prosthesis embraces all substitutes for bodily defects. So this could be in any part of the body, not necessarily orthopedics. So just remember this. 3 words: embraces all substitutes for bodily defects. Now, in the nomenclature, generally we talk about below knee, above knee, but the correct new nomenclature should be through the bone. So let's speak now as transtibial, transfemoral, and it'll be through knee and through ankle rather than knee disarticulation and hip disarticulation. Now, us as general orthopedic surgeons, the commonest would be trauma and tumor surgery, but otherwise most of the amputations, as you know, are done in the vascular for peripheral vascular disease. Like Ibrahim rightfully said, you need to do MES. Just a little point for the exam. If there's a scoring system which has scores, don't try to worry about the scores itself. Just try to keep in mind the 5 headings or 4 headings of a particular score. And then if the examiner asks you, what about the scoring? Say, I cannot recall the score, but what I will do in real life is I will make sure that I look up the score at that time, because it's a very vital decision I make. So that I did now, that you made a decision on your MES as well as with your other colleague that you want to do an amputation. All right. In a young person who's a trauma patient, what do you think the patient will come back to work faster, with an amputation or with a limb salvage with multiple Iserovs, etc.? You'll say, like you said rightfully, I will do a suture removal at about the 2-week mark. I will use, you agree that you need a good stump. And when you said good stump, we now need to know what would be the ideal stump to take things forward, right? So you'll want what is called as a shrinker sock. Will you remember that? And so you'll put on a shrinker sock for 2 weeks. Then a cast will be taken off that stump so that the prosthesis can be made, right? And you will have a temporary prosthesis given to you, on which the patient starts putting weight on it for 25 to 40 pounds. Yeah, so not full weight. So that happens. So that's your 6-week mark, like you rightfully said. Then at the 6-week mark, the definitive prosthesis would have been ready. And then the patient stands for another 2 weeks and then increases his physio and gait pattern. You happy with that, Ibrahim? So what you said was correct. I've just broken it down to be a little more slick.
Okay.
In the yeah. Now let's go back to no worries. Firas, can I carry on with Ibrahim for one more question?
Of course.
And then we'll go to someone else.
Okay.
Yeah.
So Ibrahim again. So now the next question I may ask you is, you've decided now, and I want to ask you, what if you have to do a transtibial or a transfemoral? Do you always want to preserve length, or do you want to go shorter, and why?
Yeah, I always wanted to preserve length because this
Why?
will decrease the injury expenditure
Mm-hmm.
during the walking.
So the first reason is, say, the more proximal I go with my amputation, unfortunately, the patient will have increased oxygen consumption, or you can use the words increased energy expenditure. Stick to one, whatever you want to use. Yeah. So energy expenditure is fine, oxygen consumption. Do we agree? That's one reason. And the second reason you'll say is that, unfortunately, as I go higher in my amputation, the patient's self-regulated walking speed. Remember these 4 words: self-regulated walking speed decreases. So in other words, all of us can walk faster if we want to one day, and then we walk slower. You agree? But otherwise, if you go higher, so if you have a hip disarticulation or a very high transfemoral, that patient cannot go any faster than what he is. Yeah? So that's called your self-regulated walking speed. Hence, there are 2 reasons you'll give for preserving length. One is oxygen consumption, and second is self-regulated walking speed. And then you can show 2 graphs to the examiner. So this is it. Right? And what you said was very correct about the energy expenditure. So now, Firas, can we have someone else? Thank you, Ibrahim.
Thank you, Ibrahim.
Thank you. Thank you, sir.
Thank you for being the first candidate, and for being brave. And I'm sure that will pay off.
Thank you, Firas.
Basic science Viva. Yeah.
Yes, sir.
Or it's your trauma, but let's keep it to basic science. And
Okay, sir.
you have a choice. And I show you a picture of a open fracture, and you've said, yes, I will consider amputation, or I show you amputation stump. And the question I'm asking you is that you have 2 choices. It's a mangled foot, and you have a choice of doing a Symes, which is a through ankle, or you have a choice of doing a transtibial, which is below knee, right? You have 2 choices.
Okay.
So
Yes,
tell
sir.
me the advantages of a Symes and the disadvantages of a Symes.
Sir, the advantages of Symes will be a longer stump, and since it is just through the dome of the talus, so patient may be able to even walk without prosthesis for a short distance.
Okay.
The disadvantage of Symes is, since the amputation the heel flap which we make in a Symes depends on the posterior tibial artery. So if there is any injury to the posterior tibial artery, or if there is any heel pad necrosis, the amputation stump will fail. So that is one disadvantage of Symes amputation.
Okay. Another disadvantage of Symes?
So I'm not recollecting.
Okay. Now tell me the advantage. Therefore, you've said that you would, let's say now, give me the advantage of a transtibial.
So transtibial, more options of prosthetic fitting and better fitting of the prosthesis.
Yeah, what do you mean by better fitting? What is the thing which patients would like about that compared to the Symes?
So the look of the prosthesis is like the normal leg. So the acceptance
so
of patients
pleasing. Yeah.
Cosmetically it is better. Yes, yes, sir.
Good. So you answered it very well. Only thing I'll say for everyone, the opening thing to impress. Now we just discussed 2 points which were important, like energy expenditure. So I know you felt we had discussed it, but try to say it when you're practicing with your colleagues in club. So you'll see the advantage of Symes is it's a longer lever arm, or it's a longer. Hence, I know that with a longer stump, energy expenditure is better, and the patient's self-regulated speed is better. So you've already impressed your examiner by something you can repeat all the time. Yeah. Let's say where we are. So the advantage of Symes for everyone is that, like Krunal said, you can walk on the residual limb unsupported, and in poorer countries, developing countries, this is done. Okay. What is the disadvantage of Symes? The technical word, what you were trying to say is, let's call it fat pad migration. Easy to say, easy to impress.
Yes,
all right.
Yes,
so let's call it fat pad migration. The other disadvantage is, because unfortunately, if we have to put a prosthesis on, that Symes socket is bulky. Hence, it is the word I want you to use, Krunal, is cosmetically displeasing.
Yes,
and the patient will need a contralateral raise.
Yes, sir. Yes, sir.
Hence, I would prefer a transtibial advantage would be cosmetically pleasing, better prosthesis fitting, and an
Yes, sir.
easier matching side to side, right?
Okay. Yes.
But I do know that the energy expenditure may be higher. You keep it like that, so we are clear.
Correct. Yes, sir.
Right? Now, the
Yes, sir.
next question to you, I'm going to ask you that once again, you have a proximal tibia fracture,
Okay.
open, and you made a decision to amputate. You have two choices. You can do a
Okay.
through knee, or you can do a transfemoral, which is above knee.
Okay.
Which will be the advantage and disadvantage? Start with the true knee. What is the advantage of a true knee? You stay there. I'll ask you one more question.
Yes,
So
sir.
let's go through it. If you go through a through knee, the advantage are, like we said, energy expenditure and self-regulated walking speed. Then you'll say, because of the bulbous shape of the stump,
Yes, sir.
get a better stability, and therefore for those patients who may be sitting more because they are bilateral, it may be easy. You agree? If you go very high, the patient it's a difficult for him to stabilize.
Yes,
What is
sir.
the disadvantage of three knee? It's very clear that cosmetics you cannot get because the knee joint will be at a different level. So cosmetically, use the word
Yes,
asymmetry of knee joint. And you
Okay.
can also say that in our quest, right, for giving length, which you and me want to, you
Yes, sir.
agree that we may have gone through bad tissue. The tissue is already,
Yes,
and that would lead to more problem with stump healing,
Yes.
phantom
Correct,
limb
sir.
pain. Yeah, so that's another reason to consider. Happy with that?
Yes,
Kunal?
sir. Yes, sir. Happy.
Now,
Okay.
last thing for you,
Yes, sir.
tell me what would be your ideal length for a below knee. For example, I'm showing you a picture now. Imagine it's your basic science, and I show you a picture of a stump. Tell me, where do you want to cut this bone? Where do you want to do? It's a below. What is your ideal length?
Sir, I'm not able to see any picture.
No. I'm just giving you.
So you're asking. Okay. So ideally, below knee, I would like to take roughly keep 12.5 to 17.5 bone length. Ideal stump length.
From where? From what point?
And or the other way to take is like for every 30 centimeters of height, I'll keep a 2.5 centimeters of bone stump length.
Okay, good. And so the start by saying I would always want to have a longer lever arm.
Okay.
For the same reasons which we said for any instruments of walking speed. And then say, however, for any length in the body, I want to make sure that there's space for any available components which is cosmetically pleasing. Yeah?
Okay.
So make that opening line.
Okay.
And then say, in my transtibial, just remember for everyone, for you and everyone, if you don't mind, there's something called a 5-inch rule. So 5 inches is 5 inches below the knee joint, 5 inches above the knee joint. Okay?
Okay, sir.
It's exactly what you said, which was 12 centimeters. All right?
Yes, sir. Yes, sir.
But if everyone wants to remember something because you remember so many numbers, it's 5-inch rule, 5 inches below the knee joint or below knee and 5 inches above for the transfemoral. And you tell the examiner, I do know, however, the bare minimum would be to retain my tibial tubercle and patella tendon. It makes sense for this thing.
Yes, sir.
Right?
Yes, sir. It makes sense. Yes.
Okay. Now, then say, tell me about a soft tissue coverage. What are you going to do for the soft tissue in your below?
Okay. So
what they say in trauma situations is that if you have recognized the pre-op X-ray as a severe syndesmotic injury where the fibula and the tibia was going to be separated apart, when you do your amputation, you can still put a syndesmotic screw
yes, sir.
at the level of amputation so that the weight bearing is better for the patient. I have never done it, but just out of interest, it's a good thing to know for the group.
Yes,
so stay there for a moment, Pranat. So
yes, sir.
for everyone, we use a posterior flap, diameter plus 1 centimeters. Most of the time, tell the examiner, I know I will have to do the fibula 1 centimeter shorter than the tibia. But however you say, for trauma patients, there's something called a platform theory, where the fibula is the same level. Then say, if there was pre-operative interosseous membrane disruption, then I may consider a syndesmotic screw. All right?
What was the distance? Okay.
Okay. Just keep in mind, the best answer would be just say you need to be 5 inches above the knee joint. Okay?
Yeah.
Yeah, so that's your level, like you said. So 5 inches above your knee joint. Now,
okay.
Suppose you had told me that you want to make it keep length. Is that right? You always want to preserve length. What if you make it so distal that you're just about 2 inches above the knee joint? Is that acceptable or is that not good? just go through it now. Stay there, Abdul Karim, and I'll just go through it. So for everyone, the best answer would be, like you said initially when you started, you need 50 to 70% of the femur needed. The best answer to give is a 5-inch rule. Like I told you, is 5 inches above the knee joint. Then say, however, you cannot be less than 3 inches above the knee joint. And the reason for this is exactly like we had discussed earlier, that you need space for your knee component, right? So if you're too distal, your knee component will be below the other knee and will be cosmetically displeasing, and you cannot do that, all right? So the bare minimum is 3 inches above the knee joint. The next answer you have to give is how short can you be? So suppose you have a very severe injury to the mid femur. We always want to preserve length, but what length do we need? And the answer is about 2 inches below the lesser trochanter, or 2 inches of femur is needed for it to behave like a
Please again the reasons for the maximum, why you not less than 2 inch, please again the reason.
So yeah, which one? The 3 inches is because of the knee prosthesis, right? Correct?
Yeah.
But why we don't want to remove a huge amount of femur is that you need some bare minimum of the femur before a stump can be put on, right? And that bare minimum is supposed to be 2 inches. Okay, just keep that in mind. Okay? You need 2 inches of your femur for it to behave like a transfemoral. Unfortunately, if you have such a short femur, then it behaves like a hip disarticulation. Okay?
Yes.
So we'll move on. So what now you need to know and tell the examiner, I know there are some prerequisites for a transtibial. So the prerequisite for transtibial will be, you need to have full knee extension and you need to have 70 degrees of flexion possible. Otherwise, you shouldn't be doing an amputation. And can you tell me, Abdul Karim, you know any prerequisites for a transfemoral? In other words, we want to know that there's no pre-existing problem where the patient cannot have amputation through the femur. Like you said, full range of movement of the hip. And if at all, you cannot have a fixed flexion deformity of more than 10 degrees. Yes? And you cannot have a fixed abduction deformity of more than 10 degrees. Will you remember that, Abdul Karim? There are two figures here.
Yes, 10 degree.
10 degree, you cannot have more than that. Great. So one more question for you and then we'll move on. What do you want the soft tissue coverage to be? What is your ideal soft tissue coverage? Complex skin, you mean any better word you want to use? Can you say the word full thickness skin? That's what you're saying, isn't it? You need a full thickness skin cover, right?
Yes.
And you need a muscle mass cover, yeah?
Yes.
Okay, very good. So I'll just tell you for you and for everyone what you're going to tell the examiner. So far, just to recap, we've talked about the indication, we've talked about the best stump, we've talked about length, and now we are coming to soft tissues. So you tell the examiner that my ideal stump would be mobile with a non-adherent. Will you remember that? Non-adherent muscle mass, covered with full thickness skin. And the reason is that it should be able to tolerate shear and it will distribute load to the bone. Yeah, so for everyone, I'll just repeat it because it's a good statement to make. I want a mobile, non-adherent muscle mass covered with full thickness skin, which is able to tolerate shear and it distributes load to the bone. All right, Abdul Karim. So what you said was right. Just a few better words. Yeah, good. Firas, thank you, Abdul Karim. Firas,
thank you, Mr. Mahaluximavala. I think we'll move to the next one.
Yeah.
Just want really
the next question. That if you had to, this is for everyone, the muscle repair. Remember, there's something called myoplasty and myodesis. And tell the examiner that yes, I will do a combination of both. If you have to do a myoplasty, Mohammed, what tension will you put that at? How will you decide the tension for a myoplasty? So the best you'll say, I want it to be done at the resting status. That's what you mean, yeah? So you don't want the joint to be in flexion or extension or abduction or adduction, yeah? So it's a myoplasty done at the resting status of that joint. And it's to be done without excessive flexion or extension of valgus varus so that you're not putting it into contractures. Yeah, that's the answer. That's good. And just for everyone, if you do, there's something called a abductor lurch, and you avoid that by doing a myodesis where your adductors you attach onto the distal femur. And tell the examiner, if you're talking about a transfemoral, that I do this because I want to prevent the abductors from giving the patient what is called an abductor lurch. All right, Mohammed, happy with that?
Yes, thank you. Thank you. Yeah.
Now, tell me, now we are moving on, and I'm going to ask you a question. Tell me, at the basic science level, what is the use of a prosthesis in trying to transfer load? Or do you know any different types of load transfers in amputations and prosthetics? It's not going to be asked like I asked you, but it's good to have that information because it'll score you points because you may be now shown a prosthesis and you want to talk about it. All right. So let me tell you something, and then I'll ask you another question. So for everyone, say that there are two types of load transfers when you put on a prosthesis. Say the first one is called a direct load transfer, and that's called end bearing. And the second type is called indirect load transfer, and the other word for that is called total contact. So will you repeat that, Mohammed, for me? The two types of?
Yes, load end bearing and total contact, direct and indirect.
Yeah, so direct and bearing, end bearing and total contact. Now that I've given you a clue, can you tell me in which type of prosthesis you have a direct load transfer or end bearing? Which type of amputation, sorry, in which type of amputations in the body or through do you get and you need a direct load transfer? Direct load transfer, also called end bearing, happens when I as a surgeon or you as a surgeon do a through knee or through ankle, through a joint. And then say, in this condition, the metaphysis is wide. Is that correct, Mohammed? You have a wider metaphysis.
Yeah.
You have a larger surface area, you agree? You have the Young's modulus of cancellous bone is less stiff than cortical bone, agreed? And hence, you need this bone or this end of the stump can directly take the load. Yeah, so that's called direct load transfer. So just repeat it again for me. How are you going to formulate this answer? So what do you understand by direct load transfer? In which conditions do you get an indirect load transfer? Once again, it's a difficult question, but tell me how you'll formulate it. That's fantastic. Very good. So hence, you will use an indirect load transfer. Yeah. So very good. So let's just go through it again for you. Exactly what you said. Transtibial, transfemoral. The terminal surface is not capable of accepting the load because you said narrower, correct? And bone is stiff. Yeah. And hence, you will use an indirect load transfer, and you tell the examiner, I will need a very snug fit so that the load is dissipated around not just the end, around the entire prosthetic stuff. Okay, happy with that? So start by saying phantom pain. Phantom pain is the pain which you have at the part which is removed. Then you have residual limb pain, and you have distressing pain. Okay, so in other words, pain, like you said, psychologically bad. There's neuroma, and then you talk about contractures, infection. Then you talk about bony prominences, like you said, ulcers, breakdown, and bony prominences. And then you have your problems with varicose hyperplasia. Okay. So happy with that, Mohammed? So I have asked you the two most difficult questions. So, but I hope now, it's at least when it comes to you, you can at least start talking like this about the prosthesis. Thank you very much. Prosthesis. Yeah.
Right. Yes.
Tell me the different parts of the prosthesis.
Prosthesis would have.
So just for everyone, just remember these are 4 words which you need to know. Say
Right.
every prosthesis given to you will have a socket, which is here.
Yeah.
It'll have a suspensory mechanism of some sort. Correct what you said. So this is old. This is 1960s. I'm just showing it to you just to show that you need some method of suspending your socket onto the body. All right.
Right. Right.
You said. the word which I wanted, which you said the correct part, but let's all of us use the word pylon.
Pylon.
Yeah, pylon
Yeah.
or shank.
Yeah.
Then you have some degree of the terminal, which you said, let's say a foot,
Yeah.
and you have a mechanical knee joint. So the minute a prosthetic shown to you for everyone, all 60 of you today, just say it straight away like this. There's a suspension, there's a socket, a suspensory mechanism, there'll be this is a pylon, and there's a foot, and a mechanical knee joint. Now tell me, remember when we started talking, I remember you've amputated and you've removed the stitches, you've taken a mold, and you have a temporary prosthesis given to you.
Right.
So the next thing I want to tell you is the minute a prosthesis photograph is shown to you, the word should be, is this a preparatory prosthesis or is it a definite prosthesis?
Right.
So if this photograph is shown to you, what are you going to say? It's a definite one.
Definite prosthesis. Yeah.
So let's use that word from now on. So most of the time you say definite, and the examiner asks you what do you mean by that? Say there are two types, definitive and preparatory.
Right.
So that's where we are. All right.
Right.
And now we come to the second part, is we just need to know a little bit more about the technical words which are given in most textbooks. Remember the two things, what are the modes of transfer we talked about? The two types of transfer?
Direct and indirect transfer.
Correct. So that's a transfer. It's not truly the type of prosthesis, but it leads to the type of socket. All right?
Right. Right.
So keep in mind for below knee, you have two types of prosthesis or sockets. Let's use the sockets. There's a PTB and a total surface bearing. Okay?
Right.
So we'll say the PTB is one where it depends on the patellar tendon and the tibial flare.
Yeah.
And the total surface bearing is one which distributes the weight bearing. Remember we talked about the word? Yeah. So you tell the examiner that let's imagine this is shown to you. You will say, this is what type of load transfer is this?
This is a direct mode.
Direct is mainly for your below knees, right? So it's indirect, right? Remember we talked about the indirect one is the one which is a more important one because we want something to be very snugly fit.
Right.
And we wanted to distribute the load over the entire stump, right?
Right.
So we can say, and most of the time, nowadays we don't do knee, most of the time it'll be above or below, right? So most of the time we'll be given this.
Yeah, so this is an indirect one.
Load transfer, and it's tell them that it's a pin and silicone liner.
Yes.
And now you need to know different forms of suspensions. So the old term of suspensions were belts. You remember the 1960s belts? And now you can have vacuum assisted.
Yeah, vacuum assisted.
I'm introducing words to you which you can start using if it's there. Yeah.
Yeah.
Now tell me about the pylon or shanks. Tell me imagine I'm showing you a photograph. Tell me about the pylon. You want the patient to twist, suppose the patient wants to twist. You want him to twist or not? You want to, right?
Yeah.
Okay, so you want rotaries. Right? So let's use this. So tell the examiner, my ideal prosthesis will be made of aircraft grade aluminum or carbon to make it light.
Yeah.
I will want it to have some degree of shock absorption. You used these words earlier, so very good. To have some degree of shock absorption.
Yeah.
And it could have the advanced ones have transverse rotators. All right, so you can rotate or pivot.
Right.
Then tell me a few words about knee prosthesis. So do you know any different types of knee prosthesis?
Yes.
Let's start by saying, like you said, tell the examiner, the simplest is a single axis knee, which is the lightest.
Yeah.
Then say there's something called a locking mechanism. It could be a stance phase locking. So tell them that in stance phase it locks automatically. So that's stance phase.
Yeah.
Then say, I know there's something called a 4-bar knee, which is good for longer limbs.
Yeah.
Then the more advanced
hydraulic
ones,
knee.
there are three advanced ones now. Is hydraulic knees, pneumatic polycentric, like you said, and microprocessors. Yeah. So very difficult to know everything about it. None of us as orthopedic surgeons want to know about prosthesis, but we need to know something to say. So are you happy, Samir, now to use it like this, single axis knee, and then say it's lighter. Stance phase locking.
Yes.
4 bars, and then you come to the newer 3, which are
hydraulic, polycentric, and
pneumatic. Hydraulic, pneumatic, polycentric, and microprocessor.
hydraulic, pneumatic, polycentric, and microprocessor.
Lovely. So Firaz, I'm coming to the end. So one more person. Thank you very much, sir.
Thank you, sir. Thank you.
So the last lucky person.
Foot. Okay. So tell me about the different types of prosthetic foot, or this nomenclature of them. Can you just start talking about it?
Prosthetic foot nomenclature.
Yeah, or just what are the types of prosthetic feet which we have? So let's say a picture shown to you. Are they made of carbon fiber, or are they made of at least you know so far, therefore, if an entire prosthesis shown you to, you'll be dividing into the many parts, right? So just describe the parts to me. Tell me again. There'll be a socket.
We had a socket, we have suspension, we have got fill-on, we have got a terminal device, and these are the parts.
Yeah, terminal device. Let's stick to terminal devices. Has to be the foot, right? Because the patient has to stand on it. So therefore, when it comes to the foot, you have different types of prosthesis. So I'll just tell you, and then we come there. So just keep in mind that the more modern feet are called made of carbon fiber. Yeah. And if you just keep in mind, if you see this, we see this a lot in the Paralympics. You agree? Yeah.
Yeah.
And it may be shown to you in the exam. So you'll describe this as a terminal device. You agree? Because it's terminal. You'll say it's a foot. You'll say it's made out of carbon. You'll say it's called a dynamic response feet. Will you remember the three words?
Yeah.
Dynamic response feet. Okay. And why? And then say it has keels. It has a short keel and a long keel. And this absorbs energy under load. Right? Let's go on. Before that, the question I asked you, just let's go through. You have toe amputations. You have ray resections. You rightfully said, Anwar, that you have your midfoot, which is your tarsometatarsal, also called Lisfranc, right? Then you have in your hind foot, just remember LCPS. Lisfrancs.
Yes.
C is the show part, which you said, calcaneocuboid. P is through the calcaneum, and S is through the ankle. So LCPS. The only one we need to know about is midfoot and the science. The question I asked is, why do we not do midfoot amputations commonly? Is, like you said, you have two deformities which unfortunately happen. You get equinus and you get a varus. So if you get a varus, you have to transfer your tiband. If you get a equinus, you have to do a lengthening, right?
Yeah.
And we end with, just to let you know, in a science, like you said, just for everyone, what are the prerequisites? You need a patent tibialis posterior artery. You need a heel pad to the anterior. Remember, what are the disadvantages? What are the disadvantages of a science? Can you just repeat one more time?
So that's why heel pad was
migration.
Problem.
Yeah, heel pad, migration, correct. And one more disadvantage is the socket is very bulky, so it's cosmetically displayed. Yeah. Okay. Two disadvantages. Okay. Good. Thank you, Anwar. Thank you very much. Yeah. Very good.
Very much.
Thanks. So now we go on is finish. So just for upper extremity, I don't think you'll need much, but just what I'll say is that just keep in mind, if you're shown a prosthesis, just say that there are three parts of a upper limb prosthesis. There's a shoulder part, which is the center of your functional sphere. You have your hand, which is the extreme end of the functional sphere. So I want you to just remember one word, functional sphere, or two words. Shoulder is the center, hand is the extreme, and the elbow is the caliper. Yeah, so the three parts of that. And if you're talking about where we amputate, once again, through wrist better, so you're keeping length. If you're going to do a transradial, you go through a junction of the middle and distal third. Always do a myodesis, no myoplasty. And it's very important, they say that in upper limb, your prosthetic fitting has to start very early. That's the difference. So thank you. Firas, thanks very much. I've done. So if you want to ask anyone, or if any of the senior people want to contribute, contribute, all the seniors. Yeah.
Thank you, Mr. Mahaluximavala. Really, really appreciate all the efforts and the input you are giving. And I hope that all the participants tonight, make the best of it, make notes of everything said. It's a perfect answer for all the questions that could be asked about this topic. It's
Thank you, Viras.
you clearly gave very good, clear sequence of answers and the right terminology to use. You know, there's nothing I could add to it, definitely.
Thank you.
In fact, a lot to learn.
Thank you.
Shwan, would you like? I think there've been some questions.
Just want to reiterate what you've said. This is gold. You won't find it summarized so well and so beautifully with buzz phrases or buzz words like that. Please do take note of everything that's been said. Another sentence which I remember, I'm a big fan of using multidisciplinary team in your answers. So a sentence which I would throw in there at the very beginning to buy you time to prepare your answer is to say, my approach to an amputation will be to develop a patient-centered treatment plan using a multidisciplinary team.
Very correct. Very correct.
To include your surgeon, prosthesis, prosthetic service, your physiotherapist, occupational therapist, counselors, because the psychiatric issues, your nursing team, as well as other broader teams such as your physicians for managing medical comorbidities and optimizing medical problems. Amputation, some factors that would need to be considered is the level of viable tissue and the ability of the patient to manage physically and mentally with the different prostheses that are available. And that just buys you time to then get the rest of your answer in line. It's a sentence that you should throw out. Always develop one sentence for all these topics.
Very correct. Thank you. I think let's just use the word. You need a longer amputation stump is your goal.
Yeah, I don't. So thank you very much, everyone. I think if everyone happy, we will end it tonight. We all have work tomorrow morning. So thank you everyone who took part. Again, to the 58 people who attended. Thanks to all the mentors, Mr. Mahaluximavala in particular. And we will see you again next Wednesday with another topic. We haven't decided yet on the topic next week, but we will